This video is about BAOMS quality outcomes in oral and maxillofacial surgery. It is aimed at BAOMS members, OMFS consultants, trainees, junior doctors and students interested in finding out more about our project. There will be a similar video for patients and members of the public. QOMS is the National Quality Improvement in Clinical Effectiveness Program for oral and maxillofacial surgery. It is led by BAOMS and Saving Faces. It includes a series of clinical audits to assess and improve quality of care and a series of registries to bridge in gaps in treatment and care in OMFS. How QOMS came to be. In its first oral and maxillofacial report, the Getting It Right First Time Initiative, or GIRFT, published 5 recommendations to improve the quality of the specialty's clinical data. The 5th recommendation was to deliver an efficient and patient-focused outcomes audit program for oral and maxillofacial surgery. In the wake of this report, the 2018 BAOMS president, Mr. Ian Martin, initiated a specialty-wide quality improvement in clinical effectiveness program, which became the Quality Outcomes in Oral and Maxillofacial Surgery, or QOMS. After discussions and consultation with the BAOMS membership, it was decided that QOMS would be a multifaceted project. Its objectives would be to, as indicated in its name, be a quality of care management system to develop benchmarks and quality improvement, and a clinical effectiveness program to support the development of practice-based evidence, for example, for rare head and neck conditions. QOMS should go behind those 2 main objectives and also become a tool for the continuous personal development of surgeons by supporting their quality improvement skills and their appraisal and revalidation. Finally, aware of the importance and value of clinical data, QOMS should support secondary research initiatives to develop new tools for potentially improve further the care of oral and maxillofacial patients. How does QOMS propose to achieve its objectives? Beyond the treatment and care of patients, clinical data can be used to measure the quality of care provided by healthcare professionals, develop clinical guidelines and meaningful performance indicators, and drive improvement of care and service provision. Repositories of such data are called clinical registries and are commonly used worldwide. QOMS was initially designed to comprise a series of 6 audits to cover the following OMFS subspecialties: oral and dental surgery, oncology, orthognathic surgery, reconstruction, trauma, and skin cancer. Moreover, QOMS also includes several disease or procedure-specific registries, for example, for salivary gland cancers and mandible reconstruction. Audit activities will focus on creating performance indicators, establishing benchmarks where needed, measure performance to feedback to surgical teams, and drive quality improvement initiatives to improve outcomes. The clinical effectiveness registries will be designed for developing practice-based clinical evidence. How was QOMS developed? Which criteria were used to select procedures and metrics and build the questionnaires? In this section, we briefly summarize some of the underlying principles of QOMS. Procedures can be arranged according to how often they are performed and their intrinsic risks. Low volume, low risk procedures have little or no interest in quality improvement. Low volume, high risk procedures are good candidates for clinical effectiveness registries, and high volume procedures are the prime target for quality improvement, either because of their high risk, high stakes nature, like free flap reconstructions, or because their volume means that complications are seen more often. The selected metrics should measure a clinically relevant aspect of care, which should be specific. They should be readily accessible, that is, not requiring the collection of secondary data other than that regularly documented in clinical care. They should also be actionable by the surgical team and relevant to the surgical team, patients, and the commissioners. Finally, they need to be timely, as the value of data in quality improvement decreases with time. Metrics need to be smart. QOMS therefore needs to collect the information to calculate a metric and information about factors that could affect clinical outcomes, for example, factors intrinsic to a specific surgical procedure or to a population group. Ultimately, QOMS aspires to produce risk-adjusted quality performance metrics. What are the QOMS audits? What are they looking at? For oral and dental surgery, QOMS will assess the appropriateness of tier attribution, that is referral to secondary care, and evaluate treatment of odontogenic infections. The National Third Molar Audit, led by the National Facial, Oral and Oculoplastic Research Center, or NFORCE, will contribute to QOMS by sharing data about complications following third molar extractions. For trauma, QOMS will focus on two types of injuries, mandibular and orbital wall fractures, and look at complications in terms of return to theater and readmissions. The orbital wall fractures audit will also assess long-term visual complications. For oncology, QOMS will look at complications of all major head and neck cancer surgeries and at margins and number of lymph nodes removed for squamous cell carcinoma specifically. Within oncology, skin cancer is a different subspecialty. The skin audit will be focusing on non-melanoma skin cancers and looking at their diagnosis, margin, and at establishing which sites are high risk for developing facial skin tumors. For reconstruction, QOMS will be looking at post-operative length of stay and flap survival for all head and neck free tissue transfer, as well as the timing from surgery to the commencement of adjuvant radiotherapy for cancer patients. Finally, for the orthognathic subspecialty, QOMS will be collecting data on length of stay and complications, like return to theater and readmission, for all surgeries with a special interest to Le Fort 1 and mandibular ramus osteotomies. The orthognathic audit will be the only audit in QOMS to collect patient-reported outcomes. What about the other two registries? Salivary gland cancers are a heterogeneous group of rare cancers for which clinical evidence is lacking. By aggregating the data of affected patients, a dedicated registry will allow us to better understand the natural history of those cancers and give us clues as to which treatment work. Reconstruction is an important part of treatment to restore appearance and functions in patients. Besides tissue transfers, manufactured implants are also used in reconstruction. Although deemed safe, there is little or no evidence of long-term management and complications of such implants. QOMS wants to establish the second registries to bridge this gap. We have seen so far what QOMS was and what it was doing. Next, we will briefly cover how QOMS is organized. The QOMS project team is the executive body of QOMS and manages its day-to-day activities. It is overseen by the steering committee and the BAOMS Council. The team is composed since July 2020 of the clinical lead and their deputy, the project manager, and 9 audit leads and deputies. Contact between surgeons in the field and QOMS relies in part on the BAOMS regional outcomes leads. Data is at the core of QOMS. From their collection, storage, analysis, and ultimately disposal, data represents the most valuable asset of the project. QOMS relies on a third-party IT provider. The Barts Cancer Research UK Centre, or BCC, at Queen Mary, University of London, was chosen for that role because of their extensive experience with collecting and storing data, and also because they offered us a level of service that matched our needs. For data collection, QOMS is using the research electronic data capture software known as REDCap. The BCC has also secure data storage facilities in the UK and provides a data safe haven environment and a secure web transfer service for handling sensitive and confidential information. Finally, we would like to leave you with the following points. We acknowledge that as a specialty, OMFS is a latecomer to national audit. This can partly be explained by the diversity and complexity of the conditions treated. It is a lot of undertaking and we are trying to catch up with QOMS. We tried hard to choose most meaningful outcome and have sensible data collection tools. And QOMS is far from over, and we hope that future audit activity will become richer with data capture of patient-reported outcomes relating to form and function in other audits. QOMS needs your help and participation to be successful, so do join us. Well, that is all for this brief introduction to QOMS. If you wish to read more about the project, please visit the BAOMS website. The address is given here. You will find information about QOMS under Professionals. You can also follow us on Twitter and Facebook or contact directly the project team at quoms@baoms.org.uk. That is QOMS@BAOMS.org.uk. Thank you for watching this video and let us know what you think. We're looking forward to hearing back from you.